So I'd now like to welcome to the podium our final keynote speaker, Dr. Razelle Kurzrock. Razelle is the chair of the Early Therapeutics and Rare Cancers Committee here at SWOG. Under her leadership, the committee launched the wildly successful DART, a trial for patients with rare cancers. But her reputation stretches well beyond SWOG, and she is known internationally for her innovative work in translational science. Dr. Kurzrock developed one of the biggest and best phase 1 clinical trial programs when she was at MD Anderson Cancer Center. She currently serves as the chief of the Division of Hematology and Oncology and senior deputy director of clinical science at UCSD Moores Cancer Center, and she's the director of their newly established Center for Personalized Cancer Therapy. An expert on individualized cancer care long before it was popular to be one, Dr. Kurzrock is frequently sought as a speaker and a media expert on the topic, and she appeared just earlier this year in a National Geographic cover story on the future of medicine. She is here today to give us a peek into the future. Razelle, welcome.
Well, thank you very much for the nice introduction and all the good work that's done here. I actually really love being part of SWOG. I keep on telling people that, but I really mean it. And what I'm going to talk about today is precisionalized cancer therapies. And that word brings together the words precision and personalized, because I think that is the essence of where we need to go, the next frontier. So these are my disclosures, and I am going to talk a little bit about some off-label use of drugs because that's part of what we have done in one of our clinical trials. I do several things at UCSD, but what's really close to my heart is the Center for Personalized Cancer Therapy. And as Chuck mentioned, before that I was at MD Anderson Cancer Center, and I was charged with building a new clinical trials department, a phase 1 clinical trials department that was very successful. But starting about 2007, we started integrating genomics into the fabric of that department, and it was really first-generation genomics. We had PCR-based 2 or 3 genes at a time. Then we got up to 12 genes, and that was a big accomplishment. But that's where was sort of the seeds of beginning to see, even in phase 1 patients, that if we matched them properly to the drugs, some of them could do very well. So the take-home points, which I'm going to give you right at the beginning, is to give the right drugs to the right patient at the right time, and that's the essence of precision medicine. So at the genomic level, every metastatic tumor is unique and complex. I'm from Canada, so I know a little bit about snowflakes, and so this is akin to malignant snowflakes. If you look at the crystal structure of snowflakes, it's very complicated, and each snowflake is unique, and that's true for metastatic tumors as well. In order to be precise, we have to personalize therapy. And that's where the precisionalized comes from. So if every tumor is complicated, every metastatic tumor especially is complicated and everyone is different, to be precise, we do have to individualize. And that's a little bit hard because we really haven't done that in the past. The pillars of precision medicine are genomics and immunotherapy, and while people think about them differently, they are married to each other. And metastatic disease will often require customized, individualized combination treatments, certainly not single agents. To go over a little bit of what we've been doing at UCSD, which has fed some of the clinical trials, we have a molecular tumor board that I started when I arrived at the end of 2012. It's really the essence of our making patient decisions, and we've now done clinical grade molecular profiling of one sort or another on about 16,000 patients. And we've published a little bit about the molecular tumor board, but this really brings together physicians of all sorts of from all sorts of disciplines, as well as our basic scientists, our bioinformatics specialists, our colleagues from the UCSD Supercomputer Center, and so forth. They all come together in one room. This isn't an academic exercise. This is actually to try and help make recommendations for patient treatment. And we also developed an umbrella protocol, and which we call PREDICT for Profile-Related Evidence Determining Individualized Cancer Therapy. It's a sort of a registry protocol, and it helps us do under one umbrella a sort of plug-and-play protocol, clinical trials and basic research, and bringing them all together in the translational aspect. And it's an umbrella over the entire cancer center, so almost anybody is really eligible for this. We all know that there's an issue with clinical trials with eligibility. Just about everybody is eligible for this registry, and lets us get everybody consented. So what if every patient with metastatic disease is different, as I alluded to? And I want to give you an example from a series of breast cancer patients that we did, and there's only a few patients on this slide because more don't fit, but we really found the same thing when we've looked at thousands of patients. What you notice, this is Foundation Medicine results, 236 gene next generation sequencing panel, and I think what you can see is that every patient, most patients have more than one abnormality, that's number one, and that each patient is different. And then let me just give you an example. So patient 42 has ERBB2 amplification, and patient 25 also has ERBB2 amplification. And so classically, we would give them the same therapy because they both have ERBB2 amplification. But note that each of them also have a lot of other changes, and the changes that each of them have is different from each other. So if you really think about it, what the science is telling us is that we need to individualize. We can't just give them the same therapy just because they have something in common. And it only gets worse because we're only doing genomics for the most part, but there's transcriptomics, proteomics, epigenetic changes, and more. And I think that will even further individualize patients. So this brings us for the evolution of clinical trial design. And I think there's really a lot of exciting things happening in oncology, and so we're moving along. But let me talk a little bit about what we're doing, and perhaps what we started doing in a new clinical trial at UCSD. So this is a drug-centric trial, a traditional trial. Drug regimen is at the center of the universe, and then we find patients to fit onto this drug regimen. And these patients have something in common. Initially, what they had in common was their histology, their organ of origin. They all had lung cancer, or they all had breast cancer. Now, some of our trials are what we call basket trials, and they have a gene in common. They have BRAF mutation, or they have ERBB2 amplification, or something else in common. And I do think that having a gene in common in some cases has really moved us forward, like NTRK and entrectinib. But the basic principle is the same. The drug regimen is fixed, and we find commonalities between patients and fit them onto the drug regimen. But what I just showed you is there's a problem with that if every patient's tumor is really different. So there's another way maybe of doing this, and this is patient-centric trials. So each of these patients has something in common. They both have marker A in common, but the rest of their markers are different. So in a patient-centric trial, everybody gets a different regimen. But the strategy is the same, and that's to match them to that regimen. And that's not a really good fit for what any of us have ever done. And so that creates an implementation and analysis issue. And it also creates an issue. I'm a phase 1 physician initially, and in oncology, we don't put drugs together unless they've gone through phase 1 testing, probably a legacy of the cytotoxic era. So if you want to put drugs together, it becomes really difficult if one puts that limitation on oneself that you can't put them together unless they've gone through phase 1 testing. So something that happened soon after I left MD Anderson in about 2013, I had a friend who had breast cancer, and she had metastatic breast cancer. She'd had it for a while, and our kids grew up together, and she had relapsed again. Lung was having trouble breathing, and she was was on an HER2 inhibitor, TDM1, and at relapse she was found to have a PIK3CA mutation. And so the suggestion came up to add everolimus, but the physicians said we can't do that because there's no phase 1 study with everolimus and TDM1 together. So my friend was a physician, not an oncologist though, and her husband was also a physician. She wrote me an email that really made me think about this. And this was the email. She listed the TDM1 on top, and then she listed all the rest of the drugs that she was on because she had accumulated a lot of comorbidities during the period of time that she had metastatic breast cancer. And then the subject line of the email was, "Where's the safety data?" So that made me think about what we're doing. And unfortunately, she died. But the idea sort of came forward. And in fact, what she was pointing out is that we as physicians already customize treatment every day, except in oncology. Oncology is actually the exception. So if you have two patients that walk in with diabetes, but one has heart failure and arthritis and the other has infection and depression, we individualize those drugs for the patient. We do it without hesitation. And yet for oncology, we don't do it. And again, I think that's a legacy of the cytotoxic era, but I think it's doable. So the other thing that I want to mention before I go into some of the studies that we're doing is what I alluded to about the pillars of precision or personalized medicine, really genomics and immunotherapy. And although people think of them separately, they're really a couple and they're married to each other. And the reason we say that is because a lot of the markers for immunotherapy response are in fact genomic markers. For instance, tumor mutational burden. The higher the tumor mutational burden, the better the response to immunotherapy. And then I'll make one other comment that this is actually sort of amazing because about 4 or 5 years ago, when we saw patients with highly mutated tumors, what we called really messed up tumors, we felt sorry for them. And now we're really excited because they're the ones that are going to respond to immunotherapy. So it also shows that as science changes, we can learn how to treat patients that we previously thought were not really treatable. So I'm going to talk a little bit about examples of, or an example of how we're using in the clinic cutting edge technologies. And so we have a rare tumor clinic, and this is a patient that came to us who had a high-grade neuroendocrine cervical cancer. She came from Saudi Arabia. She had previously had surgery, chemotherapy, and radiation treatment, and she came in January 2016, and she really wasn't doing well. She waited a little bit too long, and she had a large abdominal tumor, looked like she was 7 months pregnant, but it was all cancer, and impending bowel obstruction, partial ureteral obstruction. The urology consult, who at our institution is really excellent and very aggressive, said stent not indicated, suggest hospice. So we felt bad about her and said, what can we do? We don't have a lot of time. What can we do about it? But we were doing these liquid biopsies at the time, which now has become much more popular, and we've done about 5,000 patients with clinical grade samples. And so we didn't have a lot of time, so we just drew a blood, and this is the result that we got back. And she was just chock full of mutations. So the average patient has about 4 alterations on liquid biopsy, and she had about 20 plus alterations. So we took a guess. And we thought, this is hypermutated ctDNA. Maybe she has a high tumor mutational burden. We really don't have time to get a biopsy and send it off. But we have one shot at this, and under our umbrella protocol, we're going to treat her, and we're going to give her nivolumab. And I'm presenting her, so she had a great response, and left to go home in complete remission after 1.5 years. And then we looked at our patients in general that have had liquid biopsies, and sure enough, if they have higher numbers of alterations, they do better. It probably reflects a higher mutational burden. So we then built a trial that we called iPredict. and it's investigation of profile-related evidence determining individualized cancer therapy. And this was a prospective trial. Dr. Jason Siklick, one of our surgeons, is the PI on that trial. And the idea was to give each patient a customized combination of drugs that fit their alterations. And we activated that trial in 2015. We've now consented 410 patients. We've treated 209 patients. We're matching between about 45 and 50% of patients. So we have a high match rate, and this happens to be a Foundation Medicine supported trial, so we're doing Foundation Medicine next generation sequencing and liquid biopsy and so forth. And the idea, again, was to give customized combinations to patients with refractory disease, but also we have another group of patients that have newly diagnosed patients with lethal malignancies that are accruing. And actually, we just published this. When I made these slides, it was in press, but it actually got published a few days ago, and this is the bottom line. Matching patients to drugs is not a yes or no. It's actually a spectrum. So you can have higher degrees of matching and lower degrees of matching, and that is based on the fact that patients have complicated abnormalities, and the more of those abnormalities that you target, the better the patients do. So the response rate was about 50% in the highly matched patients, about 22% in the low matched patients, and then using the von Hoff model to look at the PFS in the patients that were highly matched versus their last prior therapy. So looking at the patients as their own control, 75% of the patients had at least a 30% longer PFS in the highly matched patients, while only about 36% of patients had a longer PFS in the low matched group. Now remember, the low matched group are still matched, most of them. There's a small subgroup that's unmatched, but for the most part, they're still matched, but they're not well matched. A lot of their abnormalities are, they may have one match, but most of their abnormalities are not matched. So this told us that indeed, matching more abnormalities does make a difference. And then I'll just give you a couple examples of different matching examples of patients. This is a patient with a 69-year-old patient with metastatic ampullary carcinoma, ERB2 amplification, was navigated to the MyPathway trial, which gives trastuzumab and pertuzumab, and this patient is the before and after. The patient received a partial remission that is ongoing at 35 months. This is a patient, don't do this at home, this is a 61-year-old man with metastatic anaplastic thyroid cancer, which we all know is a very aggressive disease. He was respiratory failure with intubated on the ventilator, intensive care, and his wife actually just refused to let him go. She wanted us to do something, and usually we would not, but we came to an agreement that we would give him one chance, and if he wasn't better in a few weeks, we would call an ethics consult. So he had a BRAF mutation, he got vemurafenib, and he had high positive PD-L1, and we gave him nivolumab with that. And so this is his before films and his after, and before and after films, and he did well for about a year and a half. And this is an 82-year-old man with carcinoma of unknown primary, and he did not want to get chemotherapy, so he went on our previously untreated arm. He had a KRAS mutation, and he had a high mutational burden, but with microsatellite stable disease. And so we matched him with trametinib and nivolumab. And this is his films before and after. This is his CA19-9, which was his main elevated marker. So there was some suspicion that he had a pancreatic biliary primary, though we don't know that for sure. And he had a partial response that lasted for 15 months. So I want to move on now and talk about a little bit about what Dr. Blanke mentioned about our SWOG trial with DART. This is dual immunotherapy in rare tumors. The leader is Dr. Sandeep Patel, together with Dr. Young Chai and myself. And this is for us, a really exciting trial. It's the only national immunotherapy trial that I know of. It's for rare tumors, and even though rare tumors are individually rare, if you put them together, they're about 22% of the cancer burden. And these are all the cohorts in DART so far. So it's a lot of different cohorts. And in addition, Dr. Young Chai has really led a massive amount of correlative, of negotiating a massive amount of correlative work, genomics, transcriptomics, proteomics, and so forth. So I think at the end of the trial, we're going to have a sort of TCGA of rare tumors, which is really exciting. So these are DART by the numbers. One of the questions that arose when we were putting this together is, can we even accrue on a rare tumor trial? Well, the answer is actually yes, and I will say that people almost broke down the doors trying to get on this trial. It was really popular, and it really meets an unmet need because a lot of patients with rare and ultra-rare tumors really don't have much in the way of therapy. So we activated in January 2017. There's been some stops and starts with amendments and so forth, but in spite of that, we've accrued over 550 patients with over 800 sites. We have 37 cohorts, and we'll be up to, I think, 53 with the new amendment. And the first cohort to really complete, where we've seen responses, is neuroendocrine tumors. And this is the initial results from this. What you can see is, I think, that there are responders, and some of those responders are having durable responses, but the responders are mainly in the high grade. Neuroendocrine tumors, a heterogeneous group, so it's the red-orange that are responders. And what we see is that objective response, PR/CR, 8 of 18, which is 44% of high grade, versus 0 of 14 low grade. So we're going to expand on that. It does seem like there's an important signal here for high grade neuroendocrine tumors. Other innovative precision medicine trials SWOG is running. Dr. Blanke mentioned LungMap, which I think is a terrific partnership with SWOG, NCI, Friends of Cancer Research, and a lot of sub-studies. And then the last study that I want to mention that I've been involved with, which I think brings forward another aspect, is with the Worldwide Innovative Network for Personalized Cancer Medicine, which is mission is the global delivery of precision medicine. So it's an international organization. We've just completed our first trial, which is the winter trial. And this navigated patients to therapy in 5 different countries. But it's the first precision medicine trial that includes transcriptomics along with genomics. And what we learned from this is that, bottom line is, that transcriptomics is important. We've all been doing a lot of genomics, but it turns out that at the transcriptomic level, not all gene alterations are expressed, some are silenced, and there's differences between expression and at the transcriptomic level and DNA amplification. And so I think transcriptomics will need to be incorporated into our precision medicine trials. And this was just recently actually published too. So the last slide I'm just going to mention is something I think a lot of us have not been doing well enough that we need to pay attention to, and that is the host. Yeah, she's real. No, I'm serious, she is real. So the thing is that, so is that good luck, or is this genetics? I really don't know, but I actually think it's genetics that she can be a chain smoker and be in your face about it on her 100th birthday. So I think the genetic milieu informs toxicity response, immune mechanisms, the whole microenvironment, and I think that's another frontier that we really need to look at. So thank you, and if there's any questions, happy to address them.